Record to the cloud.
Mm-hmm.
And then I'm going to hit polls. What do I do with this?
Just hit
Allow.
Allow, yeah.
Allow panelists to vote.
Perfect.
And then can I close the screen now?
You can just put it at the bottom or minimize it, yeah.
Okay.
All right, it looks like we've got 7 people on. In 1 minute, we'll get started. Anybody that's on the call already, we have posted a poll at the bottom there. So if you're interested in getting that filled out, go ahead and open up that poll and answer those questions. It'll be recorded and saved at the end. And while we wait for more participants to join, we'll just go ahead and do that poll at the bottom there. So in about 1 more minute, we can get started. If you want to pull up the PowerPoint, I'm going to do an introduction so everyone knows who you are. All right, so we've got about 7 people on right now, and it's 6 o'clock. So I'm going to go ahead and get started and introduce myself. My name is Janine Manowitz, and I'll be hosting Dr. Dave's presentation this evening. Just a little recap about Dr. Dave. He's a native of Smyrna, Georgia, who attended the Walker School in Marietta, Georgia. He got his bachelor's degree in finance and marketing from the University of Illinois, Chicago, where he graduated. He earned his doctorate of medicine in Ohio at Northeast Ohio Medical University. He was in the top 10% of his class, completed a general surgery internship with urology residency, and he had considerable experience in general urology and advanced endoscopic, laparoscopic, and robotic surgery. He currently works at Advanced Urology, and he specializes in most aspects and all aspects of general urology, with a particular interest in erectile dysfunction, voiding dysfunction, which is going to be the highlight of today's presentation, male infertility, andrology, and complex genitourinary reconstruction. He's actually even published numerous manuscripts and textbook chapters related to different surgeries. And he's passionate about helping his patients. He's a great doctor, and without further ado, I want to let him take over for our presentation today.
All right. Thank you, Janine. Can you hear me okay?
Yes.
All right, wonderful. Well, yeah, thank you for that kind introduction, and appreciate the opportunity to be here this evening and speak with the group. So special thanks to Medtronic. Again, my name is Dr. Chirag Dave. I'm a practicing urologist in the Metro Atlanta area at Advanced Urology, primarily out of the Marietta and Canton locations, but our practice has practices throughout the metro area. And so this is a kind of topic that's near and dear to my heart, and certainly helped a lot of my patients. So excited to kind of talk to you a little bit more. So, kind of a little bit of an overview. I think since the beginning of the COVID pandemic, we used to try to do a lot of these meetings in person, and obviously, it's been a tough couple years for most folks. If there was a silver lining for us, I think the introduction of these webinars has really given us a new way to connect with folks, particularly when it has to do with intimate issues such as this. I think it's just been a very comfortable way for us to be able to reach a lot of folks. And my primary goal tonight is really just to educate and then be available to answer any questions. So we certainly want to try to leave some time for that at the end. But I do want to kind of go through issues related to bladder and bowel control, and hopefully, be able to help a few of the folks that are on with us today. So as Janine mentioned, my name is Dr. Chirag Dave. And so, when we talk about bowel and bladder control, I think the questions that are listed here on the side is probably something that many people have asked themselves, which is, will I ever regain control of the bowel and bladder? how can I, function in my daily life? This can obviously be mortifying for folks. It can kind of alter their behaviors. It can be associated with social isolation, depression. How can I go to outdoors celebrations? How can I, function in my activities of daily living? How can I get a job? Patients, as I mentioned, become socially isolated. Overactive bladder, incontinence, especially fecal incontinence patients are acutely aware of where the bathroom is at all times. So, if this sounds like something you've been through or thought about, my goal with today's presentation is just to educate around this topic and mostly so we can eventually talk about therapies here. So an interesting statistics, more than 50% of people with incontinence have not brought it up to their physician. And so we really want to push awareness around this topic. As urologists, it's something that we see and treat a lot, but we know that there's so many patients out there, unfortunately, that just haven't brought this, to a primary care doctor or to friends and family. But the take-home message here is that we do have very effective treatment options where in almost all cases, we can get patients to their treatment goal, which is significant improvement, ability to spend time with family and loved ones, be able to work the job that you want, be able to socialize the way you want. So that's really what we're working towards here. So the idea is to live life without limits. Our agenda, as I said, I want to educate on bowel and bladder control, talk a little bit about the care pathway, that we implemented at Advanced Urology and is endorsed by American Urologic Association and other organizations, talk about treatment options, particularly the Medtronic InterStim system, and then leave some time at the end for question and answers. So I think the first and most important thing is just recognizing how prevalent this disease state is. Roughly 1 in 6 adults has overactive bladder, translates to about 37 million Americans. And 1 in 12 adults, believe it or not, suffer from fecal incontinence. So, if that's something that you've suffered from, you're certainly not alone in this regard. That equates to about 20 million Americans. Just to give, a broad overview, about 12 million Americans suffer from visual disturbances. About 17 million Americans deal with asthma. So those are things that we commonly see on the news and on television. Folks certainly talk about, but overactive bladder and fecal incontinence are actually more common than both of those issues. So, a common thing we hear from patients sometimes is, oh, I'm dealing with this issue, but I'm getting older, right? And so in truth, urinary and bowel incontinence are not a normal part of aging. If someone's having issues with involuntary loss of urine or their bowels, then that certainly needs to be addressed. It could be indicative of underlying health issues that we need to know about and address. But certainly, we have treatment options and don't want folks to feel like that they just need to live like this, right? So, if you're having frequent accidents, if you feel like you have the sudden urgency to go to the bathroom, if you have to plan your life around going to the bathroom, sometimes restricting the amount of food and liquids that you're taking in, then that's kind of where this conversation starts. Particularly, many patients may be going through expensive pads and undergarments. I think we really want to be aggressive about at least offering patients a way to get to a treatment goal. So when we look at the pathophysiology, how does bladder control work? We usually try to diagram this for our patients in the office. I like this image because it shows the intimate connection between the brain and the nervous system or the bladder. But your kidneys are basically big filtration devices. They filter waste out of the blood. Urine is how we get rid of that waste. So urine passes down to the bladder. The approximate capacity of the bladder is about 300 to 400 milliliters. That's about 3 to 4 hours worth of urine production. And usually when the bladder is about half full, there's a signaling pathway through the spinal cord to the brain that starts telling the brain that, hey, the bladder is starting to fill up. I'm going to need to go to the bathroom fairly soon. Let's be aware of where the bathroom is. You generally have ample time to find a toilet. And then once you're at the toilet and ready to void, the brain then sends a signal back through the spinal cord, which tells the bladder to squeeze. In the case of a male, it tells the prostate and the pelvic floor to relax. For females, there's no prostate, but the pelvic floor should relax. And the patient should be able to completely empty their bladder. And you start that cycle all over again, right? So it's that intimate connection between the brain and the nervous system, which includes the spinal cord and the bladder, that regulates this function, right? And interestingly, the bowel is controlled by the exact same nervous system. So we'll kind of talk about where the therapies coincide there, but it's a very similar process for the bowels, where again, the digestive system pushes food through the intestines. When the rectum is full, it generates a nerve signal to the brain. When you're at the toilet, the brain sends a signal back to the bowels saying, hey, we're in an appropriate place to do this, and you're able to defecate completely in that situation. So anytime there's a breakdown in that brain bladder or bowel bladder situation, we could be dealing with incontinence and other issues. So what causes incontinence? Certainly daily habits. Think about the things that you're eating and drinking. What I always tell folks is the most irritating substances to the bladder are sugar, spicy food, alcohol, nicotine, stress. These are some of the things where if a patient tells me that after I have my morning cup of coffee, I'm in the bathroom every 15 minutes, we may want to make some behavioral modifications here. Look at the medications and supplements you take, particularly things like blood pressure medicines, diuretics. These unfortunately have side effects of making people produce more urine or may make the bowel and bladder more urgent. Folks with reduced physical mobility, they may have trouble getting out of the bed at night and making it to the toilet. That can certainly contribute to incontinence. And very, very common things, pregnancy, we know can be traumatic to the pelvic floor. It can irritate, things like the pudendal nerve, which sits just alongside the bladder. Some folks have had a cancer diagnosis. They may have had the prostate removed, the uterus or the ovaries removed. Some people required radiation afterwards. People have had pelvic floor injuries for a myriad of reasons, whether that's trauma or work related. So all of these things can contribute to incontinence. So broadly classified, the three most common bladder control problems are stress incontinence, which we'll talk about, urinary retention or the inability to completely evacuate your bladder, and third is overactive bladder, which is kind of a spastic bladder. Patients most commonly complain of like urinary frequency and urgency. So what is stress incontinence? So think of this as involuntarily loss of urine, particularly when there's increased abdominal pressure. That's usually during activities like sneezing, coughing, laughing. Whenever you exercise, bend, or lift. Some patients tell me it's when they swing a golf club, when they go for a jog, when they're playing tennis. Climbing up the stairs definitely can bring on a stress incontinence episode. But this is generally thought of as weakness in the urethral sphincter, which is the outlet of the bladder. So the pelvic floor muscles and what we call the urethral sphincter has sustained some kind of injury or some kind of neurologic damage that doesn't allow it to close tightly enough to keep the urine in the bladder. So patients in the beginning will leak small amounts of urine. They may wear a safety pad, and this can certainly progress to severe stress incontinence where they have no control over keeping any urine within the bladder. And so what is urinary retention? This is certainly something we see often as a urologist. What you'll notice is, in the initial evaluation of all patients, we're doing a small ultrasound of the bladder to get an idea of how much urine is left over. So these patients often can't tell that their bladder is full, or they don't have an appreciation of how much urine they're leaving behind. They feel like they're unable to fully empty the bladder. They could have a weak or dribbling stream. Sometimes they've progressed to the point where they need to use a catheter. And so we want to group this into obstructive or non-obstructive urinary retention, right? So for males, we most commonly think of the prostate. It could be something like a urethral stricture. For females, the bladder can prolapse into the vagina. They can have, issues with the rectum and the vagina itself prolapsing, issues with the pelvic floor. All of these can kind of create an obstruction of that outflow of the bladder. And that certainly needs to be evaluated and treated based on what the reason was. But a growing area that we're becoming aware of in urology is the concept that over time, with age, with certain neurologic conditions, that the bladder may not be squeezing enough in order to get the urine out. So that may be due to a known neurologic condition, longstanding diabetes, various issues can kind of create that. And that's a distinctly different type of urinary retention, and we have different treatment options for that as well. And then what is overactive bladder? Like we said, 37 million Americans, roughly 1 in 6 people suffer from this. It's generally, the hallmarks are urinary frequency and urgency. So feeling like you're going all the time, not having enough time to get to the restroom. If it's bothersome, but you're still able to get to the bathroom, we usually call that OAB dry or overactive bladder. When it progresses to the point where you have an unwanted bladder spasm, which is so intense that it pushes the urine out, that's what we call urgency urinary incontinence. And that really means the bladder pressure is overcoming the closing pressure of the urethra or the outlet, and that's why the urine is leaking out. So these patients will have frequent leaking. They'll often lose their entire bladder because, again, it's a bladder contraction. So they have to rely on pads. There can be an odor and a stigma that's associated with this sometimes. They often rely on pads and protective undergarments. And so, patients often ask us to put a number on this. In my opinion, if it's bothersome to the patient, there's probably, a reason for us to treat this more aggressively. But generally, if you're going more than 8 times a day or more frequently than every 2 hours, we would classify that as an overactive bladder. And often there can be overlap between these, right? So a patient can have an overactive bladder, but they're not emptying all the way. So they might have a mixture of urinary retention and overactive bladder. Certainly patients can have both urgency incontinence and stress incontinence. So that's incumbent on us as urologists to kind of lay these out, discuss various treatment options. And sometimes you're going to choose one option over another based on the overlap in these symptoms. And then kind of shifting gears a little bit, again, we said it's a very similar nervous system, so it's natural that there's some overlap here, but we'll talk about fecal incontinence as well. So this is a recurring, fairly mortifying experience for patients when this is happening. Again, they can have urgency of the bowel where they just feel like they have to go all the time. Occasionally they have accidents. And some patients progress to the point where it's just passive incontinence. They have no control over when the bowels are emptying. So I think the good news, the silver lining, all of this, what we really want, the patients that are with us here today to take home is that there are treatments that can get patients back to living their life, right? And so again, this is an extremely distressing scenario for patients. Lots of folks have just kind of written it off to their age or just accepted that it's going to be the way it is, or spending lots of money on pads. But we really want to reach these patients, hopefully, and get them to their treatment goal. So there are ways to treat overactive bladder and fecal incontinence. I think the first step is seeing an appropriate professional and getting an accurate diagnosis, right? So there's a complex interplay here between the anatomy, the physiology, the neurology, biology of everything that's going on here. So I think getting an accurate diagnosis is the first step. Let's make sure we're not missing, an underlying sign or symptom of a bigger health disorder that's going on. And almost always we're going to talk about implementing some lifestyle and dietary changes. Like I said, sugar, spicy food, caffeine, these things can be very irritating to the bladder. Certain medications, we'll certainly review those things at the initial visit with our patients. But almost all patients that complain about this, I think it's incumbent on us, as healthcare providers to offer them some kind of treatment. And oral medications is often some of the first things that we'll think about treating patients with. But in my practice, I like to see patients back, fairly quickly within 4 to 6 weeks to assess how they've done on this. And we certainly have more advanced therapies that have a higher treatment success rates. And we want to move to these treatment options, efficiently if a patient's very bothered by everything that's going on. So I've touched on these things a little bit, and there's certainly a role for modifying the diet, as I've discussed. I think eating healthy, sleeping well, exercising more frequently can certainly take some stress off of the bladder. And there is a role for pelvic floor physical therapy. So we have a great network of pelvic floor physical therapists that we'll work with. And so these are kind of the first things that we'll think about, particularly with overactive bladder and fecal incontinence. Oral medications, these have been around for quite some time now. You'll see commercials on TV, you'll see aisles in the drugstore that are dedicated to this. Medications are usually a lifelong daily type medication. The literature would say it's initially effective in about 50% of patients. I think the most troublesome thing, particularly about the older generation of oral medications, is the side effect profile, right? So about 3/4 of patients were having to stop these medications due to the side effect profile. It dries the bladder out, but unfortunately, it can also dry out your mouth. It can dry out your bowel, so it can cause constipation. It can cause heart rhythm abnormalities, blurry vision. And I think, the issues recently with concern over dementia and dizziness and confusion, that has made the older generation of medications more problematic for urologists, and we're really not using those medicines as much as we used to. Newer generation of medicines have come out with a probably more favorable side effect profile. But again, you're limited by having to take a daily medication. Certainly those medicines have different types of side effects, such as raising the blood pressure and other issues as well. But it's certainly an option, that we'll generally consider early on in the disease spectrum. And then we move into advanced therapies, right? So if conservative treatments don't work, and usually we're going to know that within about a 4 to 6 week period, then we really should be thinking about some of these advanced therapies, right? And so fortunately, Medtronic, which is a very tenured company, they're really known for expert engineering, particularly in the battery space. Some of you may have friends and family that have a cardiac pacemaker, but this technology was really derived from the battery technology that was used to drive the cardiac pacemaker. But they've developed a system that can actually help with both bladder and bowel control. And it makes a lot of sense. If you go back to the early part of this talk, we talked about the overlap in the neurology and the pathway that controls both the bladder and the bowel. So it really makes sense to target that part of the nervous system to help patients, particularly when they're dealing with both of these issues. So that's really where I've had a lot of success with my patients, is kind of drilling down on the root cause of their issues. And if I'm concerned that it's a neurologic issue, or there may be an underlying nerve irritation, those are the patients that do very, very well when I recommend these treatment options. So we have the Medtronic InterStim system for the bladder. We'll also briefly talk about injected medications as the other main advanced therapy that we offer here. And really, when it comes to bladder control, it's the Medtronic InterStim system, or you're looking at more invasive surgical options, which is generally not the first option when we're kind of discussing this with patients. And so I think it's important to understand these trade-offs. Botox or botulinum toxin, this has been around for a long time. Most folks are familiar with this in the cosmetic space, but you'll see this frequently injected in the face to relax wrinkles. It is a temporary muscle paralytic. And so very similarly, we can inject this into the bladder with a camera, what's called a cystoscope, and it will give temporary muscle paralysis to the bladder, which can improve the symptoms of overactive bladder, such as urgency and frequency. So one of the issues is that it will wear off, right? Usually within a 3 to 6 month period, it'll wear off. So patients who do this usually need to come in, 2 to 4 times a year to have this medicine injected into the bladder. I think the effectiveness is roughly comparable to the oral medication. So it's a decision for the patient, usually between being on a daily pill or coming in for a procedure 3 or 4 times a year. Because it's being injected directly into the bladder, it doesn't have any data or effectiveness for fecal incontinence because it's not technically working on the nervous system. And the main risks that we have to counsel patients on with Botox is that if it works too well, that the bladder may not be able to empty on its own, right? And that can create urinary retention, which we discussed earlier. Unfortunately, it's going to take 3 to 6 months for that medicine to wear off. So patients have to be prepared that if that were to happen, they may have to pass a catheter for 3 or 6 months until the medication wore off. And then there is also a higher risk for urinary tract infections with Botox. So particularly in a patient who has a history of recurrent UTIs, I wouldn't think of Botox as the first option in this area, but it's certainly something that's included in advanced therapies and something that we'll discuss with patients. So the literature says, if patients enroll in Botox, roughly half of them, after about 2 treatments or so, will start looking for other options. So the next is the bladder control system, what we call sacral neuromodulation, or the Medtronic InterStim system. So this is a technology that we'll talk about in the kind of upcoming slides. Again, the reason I like this for patients that have overlap between bowel and bladder symptoms, or where I'm concerned about maybe a neurologic cause for their voiding dysfunction, is that this targets the root cause of the problem, which is inappropriate overactive signals between the lower part of the spinal cord and the bowel and the bladder, right? So by providing gentle nerve stimulation, we can correct that communication between the brain, the bladder, and the bowel, right? So think of it like a bladder pacemaker or a bowel pacemaker. And so what I like about this therapy is that we do a diagnostic test first, and we allow the doctor and the patient to kind of sample this therapy and prove really whether it's going to work or not before we commit to putting in any kind of implant or anything like that. So, if we decide that it works, and it's usually quite dramatic for patients, after we go through this trial period, patients, if it works, will say, hey, that's the best, 3 days of sleep that I've had in a long time. I didn't have to use any pads for the coming days. I was able to socialize during those days. We would then remove the leads, document that it worked for them, and start the process of scheduling them. Unfortunately, when you take that out, the symptoms will return. That's often what I hear from patients is, oh my gosh, why do you have to take it out? But they're very excited to know that there's potentially a therapy here that's gonna cure their symptoms. And so this technology has come a long way since I was first introduced to it about 10 years or so ago. This is now completely MRI compatible technology. There's an option to charge and recharge these. We'll kind of get into this technology in the upcoming slides, but it's certainly a therapy that I'm very excited about. So again, the first step in seeing whether you're a candidate for this or not is, like I said, coming in, making sure that we've tested the urine, make sure we've ruled out any other causes, make sure we have an accurate diagnosis. But if this is the right therapy or something that's suggested by your healthcare provider, we would do a simple test either in the office or in a procedure center, where under X-ray and with some a small amount of numbing medicine, we can insert the leads, which is a thin wire. Think of it like acupuncture, where we insert this thin wire, and then it's connected to an external device. You can see here in the picture, the patient is basically wearing a low profile belt that can go underneath his clothes, and that'll allow that nerve to be stimulated for the upcoming days. Patients will then keep a diary. Our office and our Medtronic reps will contact the patient frequently. They can go through small adjustments in the programming if necessary, and then we'll see patients back several days later to review how they did with this trial, and that's when we would make a decision as to whether this was the right technology or not. So again, this is generally an outpatient. This is always an outpatient type test that can be done in the office or with a small amount of anesthesia, just for us to see whether this is going to be a viable treatment option for patients. This is a safe and effective treatment. Patients always ask me kind of what is the data on this. So numerous studies have shown that this is very safe and effective for patients. 89% of patients that were using Medtronic bowel control therapy experienced long-term success. So 9 out of 10 patients. 76% of patients achieved success with the sacral neuromodulator for bowel control, compared to roughly 49% of patients for medications. So this is a therapy that has been around for a long time. With that, we get the benefit of numerous clinical trials, data, longer term experience with patients. And so that, obviously has been a valuable contribution to the field of urology and gastroenterology for that matter. So the next question is this therapy right for you? So you may be a good candidate for Medtronic bladder or bowel control if you have significant symptoms of overactive bladder, if you have non-obstructive urinary retention. So again, you're not emptying your bladder fully and you've been evaluated, making sure that there's nothing obstructing the urinary tract, or if you're having fecal incontinence, right? It is kind of the main therapy that I think of for patients that are having fecal incontinence. Most of these patients have tried lifestyle changes. They've talked to friends, they've talked to primary care doctors, they've looked this up on the internet. Most of them are aware of the food and other things that may be irritating to the bowel and the bladder. So certainly we would make sure patients have tried that first. And a lot of patients have, either tried and failed oral medications, or they've been offered this, but they don't want to be on a lifelong daily medication for this. And certainly if you've tried these medications, I don't think, there's a lot of utility in being on these medicines for a prolonged period of time. Usually we're going to know whether they're working, within a 4 to 6 week period. That would be an appropriate time to at least start talking to patients about these advanced therapies. So, so this patient is presumably treated, and she's getting back to doing the things that she loves, and that means everything to patients. I can't kind of talk enough about how much I enjoy, what I do, particularly with this therapy. I can think of a couple patients right away when I talk about this. I kind of always mention them. One patient in particular comes to mind. She had a history of pulmonary fibrosis. She was dependent on oxygen. Most doctors had written her off. She was unable to empty her bladder. They placed a Foley catheter, so she was completely dependent on this catheter. And she came to me just hoping, that there was something I could do to help her. She told me that she hadn't seen her family in years. She was totally bedridden from being dependent on oxygen and having a catheter in her bladder, and basically had no quality of life. And so, in her situation, we went through the test. She was diagnosed with non-obstructive urinary retention, and we did the Medtronic InterStim bladder control system for her, and she now urinates without a catheter. She told me that she went Christmas shopping for the first time in over 10 years. She's been able to reconnect with her family, and it's totally given her quality of life back. So, to me, that is really, why we do what we do, and is what's really made me excited about this therapy for patients. And so that's why I'm really excited to try to impart this, education on folks, and always excited to see folks in the clinic to talk more about treatment options. So, these are some quotes from patients. Obviously, this is an area that can be life-changing for folks. So, so I want to leave some time for questions here. Again, I think it's important, that you seek out specialists that are kind of aware of these various treatment options and have experience treating these things. Medtronic has a lot of resources, both online and presumably in print in various places, but ways for you to find specialists that are capable of offering you all these treatments today. I'm obviously happy to see any folks that are interested in talking more about this. We have a very robust group in the Metro Atlanta area with 8 locations, so kind of covering the Metro Atlanta area. So, certainly a lot of my partners at Advanced Urology are performing treatments such as this as well. I've included a phone number here, which is my office's phone number. I'm always happy to meet with patients, meet with families, answer any questions you have, but mostly just excited to educate here this evening. And with that, I believe, end the presentation. And
yes, thank you so much, Dr. Dave. I appreciate it. That was really informative. So now we're going to go to the questions and answers. So I'm going to open these up. It looks like, let's see, does insurance cover this?
Yes. So I stopped sharing my screen. Can you still hear me?
Yes.
Okay. Yeah. So this therapy has been around for a number of years. Like I said, the literature is certainly there. It's FDA approved for overactive bladder, urinary retention, fecal incontinence, and it's also now included in the American Urologic Association guidelines. And so, in order to make it into those guidelines, you have to have a big body of work, lots of patients that you've treated, and so it's certainly covered by insurance companies. I mean, I think. For urologists, if you have a patient who has overactive bladder, you've diagnosed them and offered them medicines. If they're not getting better, in my opinion, you're wrong not to offer these treatment options, right? We need to get our patients to goal. That's the reason why they're coming to us. If you've tried these behavioral changes, if you've tried medicines, it's not working, these are the next therapies that we should be offered to patients, and insurance companies certainly understand that. So it is covered by insurance.
Okay, perfect. And then the next question is, I've been to 3 urologists. Why have they not mentioned this to me?
Yeah, I mean, again, I probably need more information on that. I mean, I'm not saying that this is a treatment option for everyone. I was fortunate to train at William Beaumont Hospital in Michigan with Dr. Kenneth Peters, who is largely considered, one of the thought leaders. So I was just very fortunate to be exposed to it in my training. And then certainly being in the Metro Atlanta area, it's something that I'm discussing a lot with my patients. So again, I can't answer exactly why it wasn't offered to this particular patient, but it should be, one of the options that we think about, particularly if the patient's failing medication. So.
Okay, the next question is what happens if the battery needs replacing? How is that done?
Very good question. So, I think the published literature quotes maybe a 7 to 10 year battery life. Um, it's not on label, but certainly we've seen patients go much, much longer than that with their battery. So when we change the battery, we're not actually changing out the whole system. The battery is like a $50 or maybe an Oreo cookie size battery that goes underneath the fat of the upper buttocks area. I can usually, perform that through a roughly 1 or 2 inch incision by just using numbing medicine there. And so when the battery needs to be changed, usually we just need to open that pocket with numbing medicine, take out the old battery, attach a new one, and close the skin there, right? So that can be accomplished in about 15 or 20 minutes in an outpatient setting.
Okay. There's another one here. Can you explain the difference between the programs in the Medtronic therapy?
The difference in the programs. Is that what the question?
Yeah, that's
was?
the question. Difference in the programs.
Okay.
I think.
Yeah, I just want to make sure I'm understanding that question properly. But if it's pertaining to the programs that's on the device, generally the way that I think about it is, without getting too technical, there's a lead that we place adjacent to the S3 sacral nerve root. And so the lead is contacting the nerve or close to the nerve in different locations. So the nice thing about the program is we basically have infinite programs that we can use where we're contacting the nerve at different locations or at different amplitudes. So once the therapy is in, we basically have what looks like a Galaxy smartphone where we can switch to different programs, turn up, turn down, but the programs generally refer to what location, the therapy is contacting the nerve. And then we can go through complex programming to get the patients the results that they want.
Okay, perfect. The next one is how long is the test?
Yeah, good question. So the test is, generally takes about 15 or 20 minutes. In my practice, patients will come into the procedure center. They have a chance to meet my entire team. They come back to the procedure room. We'll usually, if they prefer it, administer like a colonoscopy type sedation, just so they're feeling relaxed for the procedure. We place numbing medicine. It takes about 15 minutes to adequately place the leads. I usually have x-ray there just to make sure that there's accurate placement. And then we'll have electrodes connected to the patient to make sure we're getting the appropriate responses. So about 15 minutes for the procedure. And then we'll go through some programming afterwards before the patient goes home. So all told, probably about 2 hours in the procedure center from the time you arrive to the time that you go home. So.
All right, perfect. So I don't see any more questions here. So if you guys have any in the next couple minutes, feel free to type those in. Oh, one more popped in. Hold on, let's see. How do they compare to the eCoin technology?
The eCoin technology. I don't have much experience with that. Janine, do you know?
I actually don't know. I've never heard of that.
Yeah, so I'm happy to kind of research that and get back to whoever asked that question. So I don't know if our hosts have a way of kind of getting some information for me to be able to contact that patient back.
Right.
I'll certainly look into that.
Yeah, everybody is specific and unique. So, if you think that you might fall under one of these therapies, the best thing you could do is to make an appointment at one of the advanced urology locations. Dr. Dave posted a picture before of that phone number. I don't know if you want to pull it back up.
Sure.
There's a phone number there that you can call to make an appointment. And then they can look at you specifically, get your history, and kind of find out where you fall in these categories and where you can get started with X, Y, and Z. There's so many locations, so many advanced urology locations located throughout Atlanta and Georgia, North Georgia. So whichever one, is closest to you is always a viable option. And, concluding this, oh, wait, we got another question. Is it, da, 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 da. I don't think that I understand. Okay. Okay. The question is how does a urology work with Medtronic? I think that question means like, this is a therapy that your office provides and that you guys specialize in. So I think that's what that question was. But moving forward, there's another one here. All right. So that concludes everything, I believe. We are good with the questions. So at the end of this, I just want to say thank you, everybody, and a special thank you to Dr. Dave for hosting this event tonight. It was really informative, and we're grateful for your time. So thank you, and we really appreciate it. Everybody else on the call, just go ahead and jot down the number for Dr. Dave's office, schedule that appointment. And there's also going to be an anonymous survey once this event concludes, and it's going to appear on your screen, but it will also be emailed to you. So if you guys want to fill that out, that would be greatly appreciated. And I hope everybody has a good night. And thank you so much.
All right. Thanks a lot, Janine. I appreciate it.
Great. Thanks. Bye, everybody.